Well, hello, everybody, and welcome to SADS Live 144. It's great to be with you here. It's been a couple of weeks, hasn't it? I'm Mike Ackerman, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. It's a great, great time to be with SADS Nation because you all rock. So on behalf of the board of the SADS Foundation, on behalf of our CEO, Alice Laura, thank you for the incredible response, the incredible turnout that you delivered 10 days ago. Remember, June 11, it's going to be a milestone moment, a pivot point in the history of the SADS Foundation for the benefit of our SADS families. And I'm speaking of the externally led patient-focused drug development. If I say that enough times, ELPFDD, externally led patient-focused drug development day. And as you know, you turned out in full force for the morning of June 11th, our families with long QT syndrome. And yours truly launched the setup, but you really stole the show in terms of making your voices heard loud and clear, that the status quo isn't good enough. Yeah, we've made a lot of progress in the care of families with SADS conditions like long QT and CPVT, but we have much, much more work to do. More work to do in quality of life, more work to do in mental health. We have more work to do. Our current therapies just simply are not good enough. And we heard you. I've heard you for years. That's what you are my why. You have motivated me and my research team at Mayo Clinic to try to come up with new solutions, new strategies, new therapies for our patients. So thank you, long QT families. And then the afternoon was filled for our CPVT families. And so the FDA got a 2-for-1 special where we had 2 different genetic heart diseases, long QT in the morning, CPVT in the afternoon, and our CPVT families spoke loud and clear and picked up right where long QT left off in the morning. And so you can still watch it. You can still comment. The FDA needs to hear from you. So please comment because the FDA, we need them to be willing to help us come up with new solutions, not be obstacles and not make the study designs so impossible to achieve that there's no incentive, no motivation, no ability for the biopharma world to want to try to come up with new solutions. FDA needs to be our helper, not hold the SADS community back. So continue to make your voices heard. And speaking of a voice, I'm going to have Aaron bring on my boss, our CEO of the SADS Foundation, Alice Laura, and have her reflect on some of what she heard and saw as the highlights of June 11. I would have Genevieve Eccles, who really deserves a huge thank you and shout out. She was the mastermind really behind it and did an incredible job. She's a little bit occupied right now with taking care of some of her own health stuff, and so she cannot be with us. But Alice Laura, our boss, can, and then we'll take your questions if you're here and joining us. So Alice.
Oh, good.
Well,
Yay. Okay. Thank you for that great announcement and summary of the PFDD. It was amazing. It was huge from the community, right? So we had a match to help us pay for it, which the community stepped up and individuals gave more than was needed to make that match. So that was the first amazing thing, even before we started, that our community really stepped up. We had 240 people attend live and put comments in and call in and etc. So that was amazing. And of those people, most of them, of course, were family members, but we also had both with lung QT and with CPBT. But we also had healthcare industry people, we had FDA people, and scientist researcher people. When they signed in, that they indicated who they were. So we had a really great mix. We were really proud of that. Amazing comments, amazing people. Even now, you're still, like Dr. Ackerman said, able to put comments in, and we are getting comments. So they'll put the link in for you to add your comment if you want. Through the end of July, we will be able to have comments that will be submitted to the FDA and part of the report. So that is very important that we heard. They hear from you. We had people from 11 different countries and the US who attended live. So that was pretty amazing. Actually, that's a lie. 14
Wow.
different countries and the US. So, and lots of them were brand new to the SADS community, which is what happened last year with the ARVC community. So even though we've had these lung QT community since the beginning of SADS, we still had a lot of new people join that hadn't been participating in the past. So that was amazing. And like you said, Dr. Ackerman, I think Genevieve's is history and witness to one of the things that we heard over and over in those comments. And that is, even though you have the best doctors in the world and the best therapy available, it is not good enough. Mm-hmm. And she had to go emergency into Mayo Clinic to get a lead replaced so that she wouldn't have a shock because it was a lead fracture. So we just need to do better in our therapies for both lung QT and CPBT, I think, is the message. And this is a good step, right?
Yeah, I think, if there is the fake news that's persisting among the heart rhythm doctor community that we have these diseases solved, that the treatments are good enough, that they work, that there's not a whole lot more to do. Well, I think our families spoke loud and clear and just busted wide open that myth and said, no way. If the doctors still think that, if FDA still thinks that, they're simply tone deaf because they're just not listening to the families.
Yeah, I think that was amazing. So we will continue to have this available so that you can still watch it and on that link, and you can comment. And then the report will be out next month. That will be officially on the FDA website as well as the video recording. So,
right. And I think also, Alice, right, besides our anonymous donor who put forward that match, which was amazing from him, and the families who stepped up and matched it, those who are hoping to be in the therapeutic discovery space with new therapies, new solutions, they stepped up and donated. And so we just want to thank and recognize, make sure I don't forget anybody. Good. Thrive Therapeutics, Solid Biosciences, Armgo Pharma.
Armgo did not, but Cardurian did.
Cardurian. Thank you.
Yeah.
And so they also need to hear from the families. They heard. I talked with one or two individuals from those companies. They were simply beyond touched and motivated even more than they currently are. Of course, companies need to be motivated to turn a profit, but they were so motivated and moved by the stories that just gave them sort of that emotional compulsion to say, what we're trying to do with this new drug is actually really, really important because the families want better. They want more. And so they need help from the FDA. I mean, they need the FDA to be saying, what is it that we need to do to adjust our study design or our endpoints to not make it so onerous that the companies say there's just no way that we're going to overcome the hurdles and the impediments being set up. And so the families, these companies, honestly, for the families, they need the FDA to get a nudge, to be helpers, to come up with new solutions rather than, impediments.
Yep. I think it was really, really successful. And thank you for you leading the lung QT. And I think that Dr. Vilde did a great job with the CPBT summary. And then the patients, of course, are the stars of the show, and the caregivers who did their stories and their comments and sharing really what it's like. That's huge.
Yeah, their stories were just, I've heard so many of the stories, but just to hear them like that was just, again, certainly beyond motivating to reaffirm for our own personal research efforts at Mayo that we need to stay in this therapeutic discovery space, that the families want more, they deserve more. And we'll, on our end, we'll keep working to try to come up with new solutions.
Yes. All
Well,
right.
Alice, thanks for your leadership in doing that. You know, this was a big lift for an organization like ours, wasn't it, Alice, to do ARVC last year for our ARVC families. First time we had ever done one. And now
Mhm.
year number 2, second time we've ever done a second one.
It's
And
huge.
not very many organizations for families that represent diseases actually do this
Right.
for their families, their
Absolutely
constituents.
true. In fact,
And
I think that we do have a record of doing 2 of them in a row like this, according to our consultants, and also being allowed to do 2 conditions in one day so that we could get both of them covered. That's not a normal, but because we were so successful last year, the FDA approved us to be able to do both
yeah,
LongQT and CPVT. So I think it was a really good win, and like you said, move the needle
yeah.
for this research. Yeah.
Well, Alice, thanks so much for your leadership,
Thank
and
you.
you and Genevieve and all that you did to pull it off. And so on behalf of the families, I thank you. So have a
Thank
great
you.
rest of your day and weekend. And I'll start with the first question. I start at the top and I take them in order so I don't cherry pick them, as you know. And you know, those are my rules on my end. I do my best. Your questions are always incredible. And I'll see, and you do your best by making them tight as Aaron gave you the instructions. First off is Allison. And Allison is asking, if my adult children have had genetic testing and don't have congenital long QT syndrome, does that mean they won't pass it on to their children? The short answer, and again, I use the questions to then give a general response, not directly giving medical advice to any specific person. The short answer is, in that scenario, yes, that would be the correct interpretation. And oh, Julie is so funny there. She jumped ahead, but I'll go back to where I was. Aaron, Julie's asking for more light on me, I think. But so if you, the index case, had genetic testing, let's say, and that genetic test revealed a definite disease causative variant for long QT, CPVT, ARVC, and then your children undergo variant specific genetic testing and are found to be negative for your variant. That means they did not get what you have. They cannot show it, therefore, because they don't have it, and they cannot pass on to their children, your grandchildren, what they did not receive from you, their parent. And so there are some caveats there. Are we sure that it's the cause? And if we are sure that that scenario of if it stopped with you and your child did not inherit it, then they cannot pass it on. This, in the cases of these genetic heart diseases, the gene does not skip generations. And Sylvia is number 2. And is electroconvulsive therapy for depression safe for those with long QT syndrome? That is a first time question, meaning in the history of SADS Live, a lot of questions, there are variations on the theme. They're all really good, but I say, oh, I've heard about that one at session, 59. But this one, I've never been asked that before. So thanks, Sylvia. And in general, the answer would be yes, it's safe, although the data is very minimal. In other words, there's just not very many long QT families, individuals who have had ECT as part of their mental health therapy to be able to say that the conduct of that procedure would be safe. Now, we have every reason to believe it would be safe. The preparation medications that they use to sedate you for the procedure are QT safe. There's nothing about ECT that ought to be heart irritating. And I'm not aware, although I would have to double check, so fact check this on this, as to whether or not the ECT stimulation would potentially interfere the defibrillator, the ICD, if for the person who has that. I actually That is one I clearly don't know the answer, and that'll be on our to-do list, is to find out whether there's any electrical interference from ECT for those who have an internal defibrillator. And our team will search that out and get that answer to you. So Sylvia, this might be the first complete stump where I really don't know the answer. So, but we will find it. So thanks, Sylvia. And Julie starts, as only Julie can, with a joke that somebody forgot to pay the light bill. Now, I asked Erin that, just for full disclosure. I said, isn't it bright enough? And she said it looks great. And maybe she meant that nobody needs to see my face anyway. Anyway, for you, Julie, your serious question, is pain a trigger for long QT syndrome? Good question, because after all, pain, like the pain here, I don't know if you can see that, is I've got a really infected finger and it is painful. So like if you hit your finger with a hammer, that pain would activate the so-called sympathetic nervous system, the fight, flight, fright response. In theory, that adrenaline could be QT agitating. Now, it turns out that of all of the portals of entry of what was the setting in which the long QT episode occurred that brought the family to discovery, that enabled us to make the diagnosis, pain has almost never been one of those that we have noted with any sort of frequency. Just has not been. So it's interesting to try to unpack that and figure out why has it not seemed to be the case. Now, like with many triggers, once you've been diagnosed and treated, most of the triggers that were potentially QT agitating, sports, running, swimming, postpartum for LQT2, most of those triggers are fully or significantly neutralized by the therapy. And so then they might have been a potential trigger if you were undiagnosed and therefore untreated, but after treatment, not so much. But pain itself, I haven't seen that as any sort of occurrence with any sort of regularity. And Adrienne, you've been referred to Mayo Clinic for your son. Oh, well, that's sweet of you. I can't wait to meet you and get to be part of your healthcare team. Thanks for that note, and I'm looking forward to that. And Dana is joining us from Instagram. So from that platform, asking, are there any studies that look at women in menopause to see if there's an increase in risk for long QT events? Asking as somebody with LQT2. Well, there's one paper that's been published, to my knowledge. I'm a co-author of it, and maybe the team can find that paper from the what was called the International Long QT Registry based out of Rochester, New York. The data, honestly, is not very convincing. So what do we know about a woman and her transitions in time as to whether certain windows of time for an LQT2 woman are long QT twitchier than others? We know that before estrogen, so childhood for a girl, is relatively low risk. We know that after the arrival of estrogen, so puberty, menarche, menstrual cycles, that from that window of time, the arrival of estrogen causes the woman to enter into a relatively higher risk window of time. I don't like to call it high, but compared to girlhood, it is measurably statistically higher. Then we know that a woman with LQT2, when she's considering to become a mom, and if and when the time is right, she should, absolutely. In other words, the old messages that used to be out there to tell long QT women that they should never become a mom, cruel, fake news, myth. We busted that 20 years ago and said, absolutely, our long QT females can become moms if they desire, and they may or may not produce a long QT child, 50-50 chance, but I have no fear if they were to create a long QT child. I have no fear of pregnancy, labor, and delivery for the most part for our long QT. But we know that for long QT2 women, that the window of time after giving birth for about the baby's first 6 to 8 months of life, called the postpartum period, that window of time is of higher risk than the 40 weeks of pregnancy and the 40 weeks before pregnancy. So meaning there's something unique about postpartum phase that is more agitating to the long QT heart, especially LQT2. Now, it turns out, unpublished but soon to be published from our group, that risk window is almost exclusively higher in undiagnosed and untreated LQT2 women, meaning after we know you have it, that postpartum window is barely a difference in risk compared. Now, what about after the end of menstruation and menopause? I don't know the exact answer for sure, but our clinic's impression has been that menopause in LQT2 women is lower risk. And that's not quite what the publication observed, but that certainly has been our clinic's impression. Now, it happens that the numbers do get smaller as we watch individuals. And so maybe we're just not seeing the cup full enough to make the right conclusion about how the content tastes, if you will. But I do not view menopause as a relatively higher risk window of time at all. In fact, as long as there's no other QT agitating factors that have arrived, other diseases, other problems that are QT irritating, I don't see that as a vulnerable window among our patients whatsoever. Jeff is asking, what do I think of the risk associated with immunosuppressants to be given regarding upcoming gene therapies? Oh, great question, Jeff. And we've had a program, haven't we, on the state of gene therapy. I think my fellow board member, former mentee, and somebody I interviewed last time, Dr. Andrew Landstrom, has given a webinar, and maybe we can post that for you. We have a lot of work to do, but it's exciting, isn't it, what's happening in gene therapy? There's several trials. We're participating directly in our program at Mayo Clinic in two gene therapy trials, one with myosin binding protein C for HCM and the other PKP2 for our PKP2 ARVC families. These are both delivered by an AAV, an adeno-associated virus. And because of that viral delivery system, there could potentially be an immune reaction. Because of that possible immune reaction, we generally give pre-infusion medications, and then during the first window of time, during that first 2, 3, 5 days. Each protocol is slightly different. These immunosuppression agents that we use to mute the body's immune reaction to the viral delivery system, if you will, have been used for a long time. So they are safe. This is part of the ongoing monitoring, though, to be sure where are we on the safety side of the equation as we try to determine whether these new therapies are not only safe, but obviously effective. So there's nothing about the immunosuppressants that for me, if I needed to sign up for a gene therapy, that would give me pause. But each person and each person's health history might be slightly different as to whether it would make sense to be part of any of the current or future gene therapy trials. Thanks, Jeff, for that question. Amanda's asking, what is the highest risk age range for LQT3 Brugada overlap syndrome? And what Amanda's asking with this excellent question is about, there's a few mutations in the sodium channel, SCN5A gene, that can give in one host the possibility of long QT3, in another owner of that same mutation in the family, Brugada, and maybe a third relative with that same mutation, they could show features of both QT prolongation and Brugada. Pretty amazing if you think about it, that there is what we call host-dependent expressivity of that mutation, meaning it's the same mutation, does the same dysfunction to the encoded sodium channel, and yet the electrical manifestation in the owner can be different. And there's one classic SCN5A missense variant called E1784K, or some of you may know of yours as GLU 1784LYS. That's the difference in the amino acid designation. And what's really interesting about that variant is it turns up as the most common variant in just LQT3 cohorts. It turns up as the number one most common variant in people diagnosed with just Brugada. And then, of course, it can do the overlap. It turns out that overall, I would put its mutation specific risk on the low end of the scale. Obvious exceptions, but on the lower end. And so I actually have many families with this specific variant. And for the most part, there's not much of a risk age range because for the most part, it's been very, very low risk. Love to see that. Obviously, there are exceptions to that. Next one on the list is, do children who experience SCA, sudden cardiac arrest, due to their CPVT at a young age, her son was 5 years old, do they have a greater chance of recurring SCA in the future than older people with or without SCA? Oh, I love the question. And it makes sense, doesn't it, that if a genetic heart disease, CPVT, long QT, Brugada, was able to rear its head in such a dramatic way early, then that might be suggesting that in that owner, it is more potent, more expressive, more flammable, more explosive, right? Makes sense. Whereas if it's never done anything in an owner's body and that owner is 55, 60, then it's feeling like pretty good bet that 60 years untreated is probably a dud. And so we also show, like for long QT, that the single greatest risk factor was prior history, meaning if it reared its head in the near past, making you do faint, seizure, cardiac arrest, that is a warning sign that it could do it again. And that's also true in CPVT. So the fact that it did it in your son at age 5 means that left untreated, it could and likely would rear its head again. But the beauty is, when correctly diagnosed, even after cardiac arrest and well treated, we expect it to not do it again. Meaning our current therapies, notwithstanding the limitations, we do a good job of preventing another explosion, another SCA reaction. So much so, remember, that in CPVT, we've argued, meaning the CPVT leaders throughout the world, that a cardiac arrest survivor due to previously undiagnosed and therefore untreated CPVT would not necessarily have to get a defibrillator. That's pretty incredible that we have gained that much confidence in our CPVT therapies that even though the disease reared its head in such a dramatic way with the SCA, we may not have to go as aggressive. So long-winded way of saying yes, likely to do it again, but only if left untreated. So lots of good news there, I hope. I'm trying to scroll down and, oh, there we go. And another from Instagram. Hi, Christy. If your child had variant-specific genetic testing and is positive for LQT2, would we consider a wider range of genetic testing since some people have more than one? Love that question as well. You SADS Nation you're amazing again today. So Christy's right that what we teach is that when we make a diagnosis of long QT in the index case, that individual gets the full test. And then in this case, that full test showed that individual had an LQT2 variant. So then the recommendation for the network of first-degree relatives, that person's parents, siblings, children, first degree relatives, they get tested for only the presence or absence of Dr. Seuss thing one, right? That variant. And then we make decisions based upon whether that family member tested positive or negative for that variant. And that's all we do unless or until the story isn't fitting. So let's say, for example, that I am testing a relative for that variant, and that relative tests negative for that variant. But when I do the ECG on that relative, the ECG shows an obvious problem. Well, now I have to do a timeout because things are not matching. So we look for what we call concordance. Is everything fitting? And when it's all fitting and making sense, then we do only what you said, Christy. But the moment that the logic is being violated, then we hit the pause button and we say, well, wait a second, maybe I need to do additional independent genetic testing on that family relative because things are not tracking correctly. Kelly's asking, does long QT always have a detectable genetic link? No, not always, but the yield of genetic testing is among the highest for long QT syndrome. In other words, if I know you have long QT syndrome, no doubt about the clinical diagnosis, and I order the genetic test on you, the likelihood that it will come back positive, telling me the answer, is about 80 to 90%. That's incredible, isn't it? Because if I know you have CPVT, the yield of the genetic test, the likelihood that it will come back positive, telling me the answer, is about 60 to 65%. Brugada syndrome, 20%. So yes, the yield is the highest in long QT syndrome of all of our genetic heart diseases, but you can be negative for the genetic test and truly have long QT syndrome, right? 10%. So a negative genetic test does not rule out the disease, but a negative genetic test would make somebody need to study you very carefully and say, am I still going to call you long QT syndrome? Because the one test, the blood test, the genetic test that ruled out 90% of the disease has come back negative. When those come back negative and I know they still have long QT syndrome, those are the ones that where we keep searching to try to find that family's new gene, their new reason, LQT 18, 19, whatever. So it doesn't always have a detectable genetic link, but mostly. Amanda's giving me a follow-up that I actually got hers right without her telling me, the E1784K overlap variant. And so for the most part, Amanda, that variant, as you heard before, is one that I love taking care of families with that one because we usually do really, really well for them. Logan's question, as I see the clock, so we're going down, and I might be almost right on top of everybody's. How high is the risk of cardiac arrest for LQT8 when given an EpiPen? Daughter has anaphylactic allergy, terrified to have to give epinephrine, but will. Yeah, we actually have an article being written about this subject because we've seen too many examples where there has been hesitation, fear of treating the clear and present danger, the anaphylactic reaction that's occurring for whatever reason, bee sting, peanut, whatever, with the EpiPen out of QT fear that it would ignite their long QT and cause the long QT explosion. Same would be true in CPVT as well. And it turns out that there's no there. The evidence of the likelihood that that EpiPen will ignite the patient's long QT or CPVT to trigger the danger rhythm, the what I refer to as the explosion, right, is really low. The other part of it has been the reluctance among allergy specialists to treat the allergies or or raising concerns that the EpiPen may not work as well because of the patient being on the beta blocker. And so have written an opinion paper, an awareness paper saying, look, we need to treat what needs to be treated. And so the risk, how high is the risk? I suppose it's higher than not giving the epinephrine pen, but the risk increase is really low. So I would have, for myself and my family, I would be doing the epinephrine pen if I'm dealing with a clear and present dangerous anaphylactic reaction, and not being hesitant or fearful that it would activate, trigger, wake up the long QT or the CPVT. And Joyce, hi Joyce, from Holland. Oh, I love that. An LQT2 mom and son. Your son is 15, asymptomatic, and on 80 milligrams of propranolol. I like propranolol. We tried 160, but that brought him to the beta blocker zombie that we've talked about. How do you feel about denervation, LCSD, as prevention? Here, it's only an option after syncope despite the meds. That's a really good question. I'm a little bit biased about denervation because our program at Mayo Clinic does more denervations than any program in the world. So we do not wait for only after syncope. So our line of entry to enabling denervation is twofold: either aggressive disease that needs more aggressive therapy, or reasonable disease for which the treatment has beta blocker usually has caused a new problem called everyday beta blocker side effects. Thank you very little. And so we do, and our guidelines in the United States support treatment intensification with denervation for either breakthrough disease or beta blocker medication related side effects intolerant. So we would be considering that in our program for a patient of that similar nature. Now, for LQT2, there's actually another option that is quickly emerging. And the we is our program combined with Peter Schwartz and Leah Crotty and Katia Odening have a major paper, just got accepted, and it's been presented nationally and internationally, so I can tell you about it, with our experience using mixilotine for LQT2. We first published a small series of 14 patients, probably 5 years ago. And now we followed it up with some significant bench to bedside and back again data in re-engineered heart cells, in LQT2 rabbits, and in about 100 patients. And mixilotine for LQT2 is very, very good. And not in everybody do they respond, but in some LQT2 patients, we are seeing 50, 60, 100 milliseconds of QT shrinkage, QT shortening. And so we have started a strategy in some of our patients where we've maxed out on the beta blocker, or we've hit the tilt button with beta blocker side effects to try to add mixilotine, shrink the QTC, and potentially lower the dose of the beta blocker. And so that's really going to become a new treatment strategy for our LQT2 community until we have new medications. And last one, real fast, Joanna's. Summer's coming up. Do I have any tips for taking a long QT baby into swimming pool for the first time? Have a blast. So again, for our long QT babies, when they're diagnosed and when they're treated, I just don't fear the water. The irritability of water and long QT is almost only in LQT1, not only, but close. So LQT2's tiny, LQT3's almost zero risk increase. And that risk increase for water swimming exposure in LQT1 people is almost always when they're undiagnosed and therefore untreated. So if you have your baby, his or her long QT cause is being treated well, our rule of thumb for our families is have a wonderful summer, enjoy the swimming pool, be aware that there could be an exception to the rule, but I'm just not seeing those exceptions rear their head. So I hope you just have a wonderful summer with your new baby, and congratulations. And on that note, we're at the top of the hour. Join us next time. And I think next time is next week already. We're doing a 2-week in a row. And the other thing is, get ready and maybe join us in Chicago, November 8 and 9 for the next International SADS conference, or likely a CME course, as well as family conference. I hope I get to see you there and meet you and get a picture with you. So until then, and until next week, have a wonderful weekend. And I know that I will, because guess what? My wife and I have grandparent duty all to ourselves with Jaden and Junie, because mom and dad are back home in Wisconsin packing up to move. That part's not good. They're moving farther away, but we get Jaden and Junie all to ourselves. So we're looking forward to our weekend, and I hope you're looking forward to yours. Until next time, take care.